Hello, and welcome to this video talking about the complex chronic condition of asthma. In this video, we will be discussing what exactly is asthma, what are some of the signs and symptoms, and why is asthma considered a complex chronic condition. We will also be touching upon a rehabilitation strategy that addresses a disability secondary to asthma. Asthma is a multifactorial, non-communicable respiratory disease. It is a global health problem affecting approximately 300 million individuals of all different ethnic backgrounds across the world. The incident rate of this disease is set to increase within the next 5 years, impacting the lives of nearly 400 million individuals in total by 2025. Asthma takes 250,000 lives each year, which equates to 1 in every 250 people dying due to asthma-related causes, more commonly in lower-class countries. Asthma is associated and affects other diseases such as obstructive sleep apnea and allergic rhinitis. The numbers of individuals affected with asthma do not remain stagnant and are rising each year. In the year 2000-2001, approximately 2.1 million Canadians were living with diagnosed asthma, which has increased to 3.8 million Canadians in the year 2011-2012. This is a 67% increase from the year 2000 to 2012. The prevalence of asthma in children is 62% greater than in adults and is more common among boys during childhood. However, it becomes more common in women during adulthood. Approximately 1 in 200 Canadians live with asthma, which is equivalent to 443 newly diagnosed per day, equating to 3,100 per week. Asthma is commonly triggered by allergens such as cigarette smoke, pollen, air pollution, dust mite, stress, cold air, pets, and exercise. They can also be triggered by respiratory infections, odors, and chemicals. These are considered triggers as they cause changes in the airways and irritate the lungs. The triggers create an immune inflammatory response, specifically of the IgE antibody. So how is asthma a chronic condition? The condition itself is chronic and affects the lower airways in the lungs, such as the alveoli, and prevents airflow due to its chronic inflammation. It is defined as chronic as the disease is persistent and will always cause the air pathways to be inflamed and swell when they are triggered. It does not heal, therefore forcing an individual to live with it long term, and the symptoms that are present can only be managed. Now, how is asthma a complex condition? A common test that is used to help with diagnosis of respiratory diseases is bronchial hyperresponsiveness, which aids in finding difficulty of breathing and the bronchioles overexerting themselves. However, it is difficult to diagnose asthma because there is a lack of biomarkers that determine the specificity of the disease, and no tests are available to distinguish its differences from other respiratory illnesses, making the condition extremely complex. Most people with asthma can be free of symptoms if they receive the appropriate medical care, modify their environment to reduce exposure to allergens or irritants, and use inhaled corticosteroids when prescribed. However, symptoms can range from mild to severe and can differ for each person. It can happen rarely or every day and affect people of all ages, often starting during childhood. Some of the common symptoms include wheezing, frequent cough, shortness of breath, and strong emotion and chest tightness. Wheezing produces a whistling sound when you breathe and can sometimes occur when you have a cold or exercise. Coughing is more common at night and may contain mucus. Shortness of breath feels like one cannot get enough air into their lungs and can occur often or once in a while. Strong emotions can affect breathing patterns by shouting, crying, or even laughing. Panic can also prevent someone with asthma from relaxing, which is important during an asthma attack. Lastly, chest tightness can be experienced during cold weather or during exercise. When these symptoms get worse, it is called an asthma attack. Asthma has key risk factors that play a role in the development of the condition. Asthma tends to run in families, therefore genetics plays a big role. Allergies are also linked to those who have asthma, such as ragweed, pollen, and animal dander. Respiratory infections also cause inflammation and damage to lung tissues, leading to asthma. Finally, the environment is another factor. Contact with certain irritants like smoke or strong odors can lead to asthma. Other factors such as allergens and exposure to infections as an infant or in early childhood when one's immune system is not fully mature yet have also been linked to the development of asthma. Lastly, exposure to dust and certain chemicals in the workplace play an important role in adult-onset asthma. Now we're going to move into the rehabilitation strategy that helps treat asthma and a secondary disability condition to asthma. The strategy that has been chosen is to have continuous positive airway pressure machines given to patients with asthma. The syndrome of sleep apnea is not currently considered in guidelines for asthma care, but many healthcare systems are working towards it being routinely treated with asthma as there is evidence that shows CPAP helps to control sleep apnea in patients with both controlled and uncontrolled asthma. To improve effectiveness and eliminate lack of access due to neglected social determinants of health, we also believe that the purchasing of CPAP devices should be as cost-effective as possible and that there should be an increase in accessibility of this treatment. The secondary disability that the treatment addresses is sleep apnea. Sleep apnea is a common disability secondary to asthma. It is defined as a clinical syndrome marked by recurring episodes of upper airway obstruction that lead to markedly reduced or absent airflow at the nose and mouth. This is typically seen in older age adults who have asthma. Those with obesity and asthma, as well as individuals with uncontrolled asthma. There's also a confluent morbidity effect as patients who take inhaled steroid treatment to manage their asthma also have a higher risk of experiencing sleep apnea compared to those who do not. This is because this medication negatively affects the upper airway dilator muscles and therefore acts to promote sleep apnea. So how does the treatment work? The CPAP therapy helps to decrease the levels of TNF-A, which is a powerful pro-inflammatory cytokine that impairs smooth muscle contractility in the airway. Doing such, CPAP therapy's ability to decrease the cytokine helps to treat sleep apnea through decreasing the inflammation that causes it. This therapy treats the inflammation in the airway just like inhaled steroids are meant to, but without negatively affecting the contractility of the airway muscles for respiration. There is much evidence that shows, due to sleep apnea and asthma's similar pathogenesis of the upper airway, CPAP therapy can help to control both sleep apnea and asthma. Now we'll go into the summary of the research publication. The research publication chosen examines the effectiveness of the chosen strategy, continuous positive airway pressure, that addresses obstructive sleep apnea, a secondary condition to asthma, which is currently the gold standard for this condition. The article describes a prospective cohort study that consisted of two main aims: to examine the changes that occurred in regards to airway responsiveness and quality of life in stable asthmatic patients who suffered from OSA, looking at the effects 6 weeks before and then after their nocturnal CPAP treatment. The study consisted of 20 subjects who were all over or equal to the age of 18 and diagnosed with asthmatic obstructive sleep apnea syndrome, and who were registered in 2 main hospitals in Quebec. Now moving on to the study design. All study participants had to undergo 3 consecutive methacholine inhalation challenges measured 2 to 3 days apart from one another before entering the study. The methacholine challenge is done to determine whether or not an individual has asthma and works by causing shortness of breath and wheezing in the individual. Baseline asthma and obstructive sleep apnea quality of life questionnaires had to be completed by participants so that there were comparisons available for the test results and effects. The participants also had to undergo an assessment of their atopic status, which is a genetic tendency to develop allergic-related symptoms or diseases like asthma. This was done via skin prick tests to common inhalants. Finally, gastroesophageal symptoms and anti-reflux medication usage were also measured via questionnaires. Next, a CPAP titration was done during a full-night polysomnography, which is a sleep test done to diagnose sleep disorders using measures of brainwave, heart rate, breathing, and more. After this, the CPAP treatment was started by participants at home, and after the 2nd and 4th week, a research nurse would contact these patients to review the adaptation to the treatment and the control of their asthmatic OSA. Finally, after the 6 weeks, objective CPAP application was determined through information from the CPAP unit. In addition, an in-laboratory polysomnography was repeated with the CPAP therapy as arranged at home. Then the airway responsiveness as well as asthmatic and obstructive sleep apnea quality of life questionnaires were re-evaluated to compare to the baseline questionnaires. These quality of life questionnaire scores were reported on a scale of 1 to 7. The higher score meant improved quality of life, and the questionnaires were divided into 4 domains: emotional function, environmental stimuli, symptoms, and activity limitation. Moving into the study results and discussion of the study research publication. After the nocturnal CPAP intervention, the apnea-hypopnea index dropped significantly, meaning that the number of apneas and hypopneas per hour of sleep for these individuals dropped with CPAP treatment. Furthermore, the CPAP treatment did not result in major changes for airway responsiveness. There were also no major changes in forced expiratory volume. However, there were significant positive changes statistically and clinically in regards to the asthmatic and OSA-related quality of life. The apnea and hypopnea index was related to improvements in the environment, symptomatic, and emotional domains of asthma-related quality of life. Moving into the critique of the research publication. The research study was effective because it included results and findings related to their stated research questions. The study's aims were to examine the changes that a 6-week CPAP treatment resulted in relation to airway responsiveness and quality of life in individuals suffering from asthmatic OSA syndrome. Using the PICO method, we will examine the validity and quality of the study design in this research publication. Starting with the P for population. The population is clearly stated, which is stable asthmatic patients ages 18 plus who suffer from newly diagnosed asthmatic obstructive sleep apnea. The study also includes inclusion and exclusion criteria for participant selection. Next, we have intervention. The intervention is clearly stated. The research article clearly states the intervention that will be taking place in order to examine the effects airway pressure treatment over a course of 6 weeks. The article explains in depth how the intervention will take place and how it will be measured in its effectiveness as well. Then we have comparison. The comparison is clearly stated. The research article clearly states that the comparison for the study experiment results that will be baseline measures, or essentially measures from when there was no intervention present for these individuals suffering from asthmatic OSA syndrome. This is evident, as mentioned previously, that they examined the effectiveness of the CPAP treatment by comparing the results at the end of the study to the measures taken at baseline to see if there was any improvements in the chosen domains. Finally, we have O for outcome. The research article states that the main outcome or aim of the study is to gain more insight on and examine the effectiveness of specifically CPAP treatment on patients suffering from asthmatic OSA syndrome. This was achieved as the study was able to conclude the effectiveness described above. One of the limitations found in this specific article is the potentially small sample size of 20 subjects, as that may lead to decreased ability to generalize the findings to the larger population and decrease the representativeness of the larger population. However, the authors of the study decided that it was a large enough sample size to complete the aim of the study successfully, which was to evaluate the effect of CPAP treatment on asthmatic OSA quality of life and airway responsiveness. This is because it would allow the detection of major changes in proactive concentration. The second limitation of the study, specifically discussed in the article, is the lack of a control group consisting of stable asthmatic patients without OSA. This limits the authors from making a firm conclusion that the improvement in the quality of life in regards to asthmatic OSA was specifically only because of the CPAP treatment used. It is possible that there were other reasons for the improvements observed, such as a placebo effect of the CPAP treatment or increased adherence to the treatment during the course of the study. The research article raises discussions regarding the directions for future studies on this topic, and it is recommended that a larger study should be done in the model of a randomized controlled trial, using moderate to severe asthmatic patients to find more accurate results on the effects of CPAP treatment on asthmatic OSA quality of life and control. Although CPAP is the gold standard strategy in regards to treating asthmatic OSA, more research should be done on its complications and how to address them before we adopt this in the local context. By looking into more studies as to how we can address the issues, we can learn more about the effectiveness as well. Continuous positive airway pressure can be time-consuming, as well as the findings with this are usually limited, since there is lower quality of adherence of CPAP in the patients. Although it is very effective in diminishing apnea, it does depend mostly on making sure that CPAP is used enough and regularly. Despite how effective this treatment is, the inability to adhere properly limits this treatment's efficiency. What is usually failed to understand is that some patients are unable to tolerate CPAP. Failure of CPAP usually has some commonly cited side effects, including dermatitis, rhinitis, epistaxis, nasal discomfort, congestion, mask leak, aerophagia, and claustrophobia. For those who fail to tolerate CPAP, there has been further options in development available for patients. Advancements have been made in pressure technologies as they have created pressure that is lower, which can be sent to the airway of the patient. The higher pressure from CPAP can have a negative impact on patient comfort and create more side effects. Other developments are also available, like bi-level positive airway pressure or auto-titrating devices. These technologies help with the variation of the pressures received and help demonstrate better quality and outcome with less impacts in CPAP. These developments can help alleviate some of the pains associated with the use of CPAP. This concludes our video on the complex chronic condition of asthma. Thank you for watching.